for this interactive session. Our first presenter is Dr. Ahmad Ibrahim Abdul Muhandib. He is a consultant nuclear medicine and molecular imaging radiologist from Riyadh, Saudi Arabia. He will start the proceeding. I think you all got the gadgets. Okay, can we start? Thank you.
Thank you, Chairman, and I would like to thank the organizing committee for their kind invitation and their great effort in this organization. We'll start our interactive session. Hopefully everybody is still able to accommodate the session. This is the final session in the symposium. Set by case number 1. I will not give a lot of history because the history mostly is the same in almost all patients. So we'll do the images. So this is FDG PET scan. And this is a question, what's your finding? FDG avid lymphadenopathy above diaphragm, FDG avid lymphadenopathy below diaphragm. Both of them FDG avid lymphadenopathy above and below diaphragm with cardiac uptake. Can we start now, please? Okay, good. This is the image again. Next question, what's your differential diagnosis? Lymphoma, tuberculosis, sarcoidosis, none of the above. So 50% said lymphoma. Go back to the image. So here we can see the lymph nodes clearly above and below the diaphragm, even here in the inguinal or external iliac, distal external iliac. But this activity in the heart is abnormal, definitely abnormal. This is not the usual smooth myocardial uptake you expect if you exclude the intensity even. So the finding was the FDG avid lymphadenopathy above and below diaphragm, along with cardiac uptake. And lymphoma is in the differential, definitely, as well as tuberculosis and sarcoidosis. And in this patient, the diagnosis was sarcoidosis, and it was histopathologically proven. And there was myocardial involvement of the disease. This is the same images, the cross-fused images. You can see the FDG avid mediastinal nodes, hilar nodes. This is the intense cardiac activity, which is, it's like ill-defined heterogeneous activity and intense involving biventricular myocardium. This is below diaphragm, CT images, portocaval nodes, avid, aortocaval, tiny one here, and also right distal iliac. So we'll go to the case number 2. Another FDG avid, FDG PET CT. So what's your finding? FDG avid lymphadenopathy above and below diaphragm, FDG avid bony lesions, FDG avid brain and spinal canal lesions, FDG avid prostatic lesions, all of the above. Okay, good. So nobody saw the FDG avid bony lesion. It's difficult to tell from this image. So let's go to the differential diagnosis. It's the same slide before, so what do you think? Lymphoma, tuberculosis, sarcoidosis, or none of the above? Good, sarcoidosis is out because it was in the first slide, so this is why it's 0%. Lymphoma and tuberculosis. And this case was tuberculosis in HIV patient. See the images for the same patient. See the brain lesions. This is a fused ANT brain, and you can see this extraaxial or cortical base lesion with the surrounding edema with corresponding FDG avid lesion and surrounding photopenia related to the edema. This is another lesion in the brain, down in the mediastinum. And the importance, if you can see here in the CT, you can see the necrosis here. See this hypodensity? This is necrotic changes in the lymph node, which point more toward TB, though it's not pathognomonic. More hilar nodes, spinal lesion, and even he has retroperitoneal lesions, FTG avid node, bony lesions, muscular lesions, and prostatic lesion. And this proved to be a tuberculosis. So the take-home message from these, not all FDG avid lesions above and even lymph nodes is a lymphoma. There is a great overlap between lymphoma and tuberculosis and even sarcoidosis with FDG, because FDG is not specific. It's sensitive. It pick up the hypermetabolic lesion, but what is it? There is a great overlap, especially at our countries, whereas grammatous disease is considered with high prevalence, especially TB. So you have to include TB in the differential of your even lymphoma suspected cases. Go to the third case. FDG PET scan. I'll give you more images even in this one before the question. So what's your finding? FDG avid lymphadenopathy above diaphragm, FDG avid paraspinal lesions, muscular FDG activity, all of the above, or FDG avid lymphadenopathy above and below diaphragm. Okay. So it goes more with muscular activity and no FDG avid lymphadenopathy above diaphragm. So how about this lesion here? So what's your differential diagnosis here or diagnosis? Lymphoma, tuberculosis, paraganglioma, psoas abscess, or extramedullary hematopoiesis. Psoas abscess is a good answer, but the problem with the psoas abscess, it's quite unusual to have it bilateral. Usually it's unilateral, and this is more or less symmetrical, and even more, there is this neck symmetrical activity in the muscles. So all these, in fact, as is a muscular activity, normal variant, whatsoever the cause, probably the patient is stressed from this paraspinal lesions. And the answer was that it was extramedullary hematopoiesis changes in this paraspinal lesions in CLL case. And this is quite, common to have this low-grade activity. If you see the images here, this is not considered high-grade or uptake. See it here, see it in the just above the mediastinal blood pool activity, considered like mild heterogeneous activity of FDG. And if you see more images here, see it's bilateral, paraspinal, and this is the muscular activity in the neck. This is just the normal looking psoas muscles with the normal variant activity. So that case was extrapoietic hematopoiesis with mild FDG activity in leukemia patient. Next case. What's your finding? FDG evident lymphadenopathy above and below diaphragm, below diaphragm, abdominal aortic activity, or all of the above? Okay. So what's your differential diagnosis? Lymphoma, carcinoid, infected abdominal aortic aneurysm, atherosclerosis, or vasculitis? Okay, it's always a dilemma when you have atherosclerosis or vasculitic uptake or infected aneurysm. And in fact, the answer was infected abdominal aortic aneurysm. If you go back to the images, this is a fused images. You can see the large aneurysm which was stented even, and with the peristatic FDG activity, soft tissue thickening in the CT, ill-defined stranding. This is the coronal images. This is the sagittal images, show you the false lumen and true lumen with the activity in it. So next case. No finding, it's very obvious. What's your diagnosis? اي لا هذه additional. خلاص أنا I'll go from it. So what do you think? This is vasculitis. And I brought this case just to show you the difference between vasculitis, where you have this diffuse luminal activity or wall activity of the large vessels, and it shows here very nicely in the large vessel abdominal aorta proximal iliacs, and you can see even the aortic arch, this ascending and the major subclavians and carotids. And you can appreciate now the difference between this one and this one here. See this patchy heterogeneous activity in the midline of the abdomen, nothing much in the other vessels. So this tell you this is more of localized process going there, which goes with the infection, especially if you know there is aneurysm. And if you see the vasculitis image, this is more of systemic disease, diffuse involvement. So this is more homogeneous and intense activity. And you have problems sometimes differentiating activity from vasculitis or atherosclerosis. But usually the atherosclerosis is heterogeneous, goes with the plaques, and it's milder than vasculitis. Next case. What's your finding? Brain lesions, spinal canal lesion, exiting nerve root lesions, FDG evident lymphadenopathy, 1 and 3 or 3 and 4. Okay. So what's your differential? Lymphoma, tuberculosis, extramedullary hematopoiesis, none of the above. It's none of the above. So what you are thinking about, which differential? The distribution here is quite typical. If you see it, especially with the lateral view, you can see this is the activity along with the paraspinal region, and there is no lymph nodes here. You can see a lesion here at the skull base level. So that one was a peculiar case of CNS lymphoma, and it was isolated leptomeningeal involvement just at the exiting nerve roots. This is the brain images. You can see this lesion here at the basal cisterns and the CP angle down in the CC junction. And this is the coronal PET images. If you see it, this is along the exiting nerve roots. See, this is the exiting nerve roots. This is the sagittal images. It's clearly you can see the dot of activity here just between the bones, which tell you this is at the exiting nerve roots here. So we'll go just this is a quick slides, and I wouldn't accept less than 100% at the end of the symposium or conference. So name the tracer. Okay, not about 2/3. Yeah, this is fluoride. This is a bone agent. And show you the normal distribution, and this is a case of kyphoscoliosis here. Second one, name the tracer or the scan. So this is a choline. This is the normal distribution. This is a case of prostatic cancer with metastatic iliac node. Next one. Should be easy. Okay, this is a gallium scan. And just one point here. See the difference between this one and this one. So when you review a PET case, you have to play with the window, especially in FDG with brain lesion, because otherwise you're going to miss these lesions if you don't reduce the contrast or intensity in the brain. I noticed that most of the people are mixing the choline and the gallium, especially even from previous interactive sessions. So you have to go to the target organ. What's the target organ and octretate? It's the spleen. So the gallium is always the octreotide. The spleen is higher than liver. But in choline, it's the other way. The liver is higher than spleen. If DG is clear, you're going to have brain uptake. That's it. Thank you very much.
Sorry for that. I thought the presentation was already loaded. So this is the first case, 48-year-old maternal breast cancer 5 years prior. She's now in for a follow-up screening mammogram. Here is her left breast images in 2008 and then 2 years later in 2010. And then her MLO images again in 2008 and in 2010. And the radiologist reading the mammogram had determined that the breast changes were asymmetric, but only slight changes in 2 years. She recommended follow-up with ultrasound. This is the ultrasound image. And the ultrasound showed only low vascularity, but given the patient's history, they had recommended a biopsy. But when the patient went to biopsy, they were unable to locate a biopsiable lesion for biopsy. So they recommended for the nuclear medicine case. So this is the nuclear medicine image. A little bit out of organization here, but you get the idea. Left and right breast images. So which of the following best describes the BSGI? A focal abnormality of high intensity, diffuse patchy uptake, normal heterogeneous pattern, high intensity focal abnormality with extending linear enhancement, suspicious for malignancy, or no abnormality seen. How do we do? Oh. And those who had replied C would be accurate. You can see there's a focal abnormality in the center there, indicated by the circle. But then where the arrows and the lines are, where the arrows are, there's some linear enhancement. It's actually not displaying very well on the overhead, but there's some linear enhancement that's suspicious for extensive malignancy. And this is a common appearance of ductal carcinoma in situ, extending beyond the area of the breast cancer itself. So this is that patient's second look ultrasound, again, for the purposes of biopsy. And the diagnosis in this patient was invasive and in situ carcinoma, grade 2, no negative. 70-year-old patient with dense breasts, no personal or family history, screening mammogram. The screening mammogram is bilaterally slightly asymmetric, heterogeneously dense, breast tissue, scattered coarse calcifications in the right breast. No specific abnormality was seen. Again, they recommended an ultrasound evaluation. So here are a multitude of ultrasounds. Ultrasound found multiple indeterminate findings bilaterally without a well-defined mass, and therefore they recommended the nuclear medicine image. So here's her nuclear medicine image. So which of the best describes the BSGI? Diffuse patchy pattern, normal heterogeneous. Left breast high intensity focal abnormality, right breast large area of intense regional uptake in the inferior portion of the breast. High intensity focal abnormalities bilaterally or no abnormalities seen. So most said B. The answer is actually C, left breast high intensity focal abnormality, right breast large area of high intensity regional uptake, indicating that it wasn't focal to a specific area like this, but it was actually a more regional presentation. And this is a fairly common, this regional presentation is a more common language within breast imaging. This type of regional appearance is common in infiltrating lobular carcinomas and in DCIS. MRI also demonstrates a similar pattern in these kinds of cases. So here's her post-BSGI second look ultrasound. Again, ultrasound is very useful to look at things afterwards, very large items. And you see in the right breast there's extensive grade 2 ductal carcinoma in situ, and in the left 2 centimeter lobular. 63-year-old, no personal history, no family history, in for screening mammogram. Again, the screening mammogram is showing these asymmetric bilaterally dense breast tissue. They actually suggested whole breast ultrasound. And again, this is very difficult to do clinically, this whole breast ultrasound. And in the whole breast ultrasound, these are the findings. Whole breast ultrasound had multiple abnormalities noted, of things everywhere within the breast tissue. And they made the recommendation for the nuclear medicine study. And this is the nuclear medicine study. So, right breast focal abnormality of moderate intensity, B, diffuse patchy uptake, no abnormality seen, or no abnormality in the breast tissue, focal abnormality seen in the left MLO near the axilla. I'm glad you caught that. It gets missed a lot. People fail to really pay attention to these axillary base areas. I had mentioned it earlier in one of my talks that the lymph nodes can be positive due to malignancy, infection, or poor injection technique. And so if you make a subcutaneous, if they extravasate the dose subcutaneously, you can have these types of uptake in the breast without actually pathology present. So that's the case. This case, that's what happened. They extravasated the dose. "58-year-old, no personal history or family history, again, in for screening mammogram. So she has a suspicious asymmetry. You can see it there, the spot in the breast. Some questionable findings on the left breast. So here's her BSGI. This one's interesting. So there's an error in both the BSGI and actually in the mammogram. Is that error poor positioning of the right breast, missing the inferior portion of the breast? Poor positioning of the left breast and failure to keep the nipple in profile? C, both A and B, or D, neither A or B? Excellent. The answer is C, both A and B. If you look very closely, and this is true in the mammogram and in the BSGI, and this is something to be very careful of, nipple uptake is a normal variant. And if they're not careful when they're doing the positioning and they roll the nipple under or over the breast in the positioning, they can basically make it look as if there's a lesion inside of the breast when there's actually just a nipple uptake. And in this case, they also made the error of not getting the most inferior portion of the right breast on the detector well. Probably didn't hurt this case. We see in the mammogram that it looked pretty normal, but it was a mistake. Case 5, this is a premenopausal woman of high risk, 2 first-line relatives with premenopausal breast cancer, no significant personal history, no cancer history of her own. Screening mammogram is very dense, and the BSGI is recommended for further evaluation. So her first BSGI was done on day 24 of her cycle. You can see the heterogeneous pattern there. And they decided to repeat her imaging, which was done on the 12th day of her cycle. And you can see the other image. For premenopausal women being screened for malignancy, which phase of the menstrual cycle should be avoided if clinically possible, based on those images? The answer is D, the luteal phase. Although this is a rare example of severe hormonal influence on uptake patterns, there can be some heterogeneity present which complicates interpretation. And I don't really have solid data for the 20%. It's really kind of more of a observation. And I think that the important thing to understand here is that centers generally consider timing only in premenopausal women with no current cancer diagnosis. And when they do decide to do that, they'll do it between days 2 and day 14. Patients of high suspicion or known malignancy, there's no attempt to do timing. It doesn't make the imaging unreadable, but it can complicate interpretation. But we don't want to make those patients who are undergoing cancer therapy wait for that therapy. Case 6, this is my last one, I think. 45-year-old patient, no prior history, no abnormalities, no significant risk factors. It's very, very plain. She's in for a mammogram. So she has these 2 masses that overlie each other slightly, and they're enlarged since her previous mammogram. So they suggested the nuclear medicine evaluation. And the nuclear medicine evaluation shows this focal abnormality at 4 o'clock in the contralateral breast and only very little activity, actually in these very large masses that were contralateral. By ultrasound, that's what they look like. And by MRI, this is what the MRI looks like. For this case, the BSGI and MRI are remarkably different, basically because of MRI is imaging hypervascularity of the tissue and therefore is rendered nearly useless due to severe adenosis. Or B, in BSGI, tracer accumulation is roughly proportional to blood flow, desmoplastic activity, and cellular proliferation. C, the adenosis, while it's highly vascular, is not as proliferative as a malignant lesion. Or D, all of the above. It's okay. And the answer is D, all of the above. And, it's fairly obvious. One of the primary limitations for breast MRI is the sense of vascularity. The machine is wrong? Yeah, yeah, okay. Oh, there we go. There you go. Again, this is the explanation, that the MRI is highly vascular, whereas in both the nuclear medicine type of techniques, we're imaging slightly different factors of the tissue. Thank you.
All right, I don't think I quite understood the question and answer session, so I did it sort of like I used to do it in Stanford. After we gave a lecture, we would frequently ask questions to really see who is paying attention to the lecture. There are a few cases buried in here, but it's just trying to understand what parts of the lecture were clear and which were not. So which of the following statements is true? F18 FDG diffuses throughout the body and is taken up only by cancer cells. B, FDG diffuses throughout the body and is cleared via the kidneys, thus lowering radiation to the technician and the physician. C, that FDG is a cancer-specific radiotracer. Or D, FDG requires capillary formation and flow to reach the cancer. Do I have to press anything? Okay. Okay. Technology is wonderful when it works and everybody's coordinated. Then there are those days.
I think the computers want to go home.
I think it's tired. You have a question? No. Oh, show of hands. We could have done that. Very good idea. He's only one slide away, though. Next one. Okay, everybody's had a good chance. Let's all vote. And the answer is all right. So all of those of you that had B, that is correct. It really diffuses throughout the body. It really has the advantage that it lowers the background. It clears the radiotracer. As it's being cleared out of normal tissues, that means it's back in the vasculature to be taken up by the cancer cells. So over time, you can actually see the FDG uptake in normal tissues go up and then go down, and then delayed imaging will see it go up in cancer cells and continue to rise as it grabs the FDG that was spit out from the normal cell. So that's the advantage and the reason that you can use a lot of PET imaging 2, 3, and 4 hours post-injection. Next slide. Which statement is true? High-resolution PET uses both nuclear and X-rays to provide those images. High-resolution PET can only be used for breast cancer imaging. High-resolution PET can identify cancers as small as 1.5 and 2 millimeters in size. And the high-resolution PET also has the same spatial resolution as whole-body PET imaging. All right. So the answer is C. Most of you got that. It has the sensitivity, spatial resolution of 1.5 to 2 millimeters in size. These are images that you can put in your brain. The whole body PET-CT, the average spatial resolution is between 4 and 7 millimeters in size, depending on the type of scanner that you have. So here's a clinical case. A 63-year-old woman was found to have DCIS in the left breast, identified on mammography. That was due to the calcifications and had a stereotactic biopsy. The right mammogram, as you see here, was read as normal. The question for you is any further evaluation of the right breast needed? No, mammography sees all contralateral cancers. Number 2, yes, ultrasound screening of the contralateral breast is always recommended. And 3, yes, cancers can be hidden in dense breast tissue. So what would we do? We just have DCIS on one side. We've already identified it, and it's normal on the opposite side. So we do have, I'm glad people were paying attention. This is a real case. You know, prior to high-resolution PET, not much would have been done for this woman, and she would have been treated for her DCIS in the opposite breast. And then a year or two later, we would have been able to see through that dense breast tissue with another mammogram, or maybe she would have felt a lump in that time frame and then would have gone back in. The fact that we have a mechanism now to interrogate both breasts while we're planning for the surgery on the right, we could actually find that contralateral cancer. Next question. Select the true statement. High-resolution PET-guided biopsy is possible, but is very difficult. Nuclear imaging cannot be used for biopsy due to the high radiation to the physician. High-resolution PET-guided biopsy allows one to confirm adequately sampling by imaging the sampled cores of tissue. And everybody was paying attention. That is the real advantage of the high-resolution PET imaging, is that we can look at the cores, and that is really critical. Just like in stereotactic biopsy, when you see the calcifications and you're going after the biopsy of the calcifications and you like to look at the calcs in the cores, the fact that you're going after a hot spot, you can then look at the cores and ask yourself, did I get that hot spot? If not, you can retarget, rebiopsy as many different times as you'd like. You can also biopsy multiple lesions in the patient at the same setting. I think the most we've done is 4 biopsies, 2 on one side, 2 on the other. All of them did end up being cancer, which required bilateral mastectomy in a woman that only had had 1 cancer identified before all of that. So let's go on and select the true statement. Axillary imaging cannot be done using high-resolution PET. Imaging the axilla can provide information on local regional spread of cancer with a high degree of accuracy. Axillary imaging should replace lymphoscintigraphy. Axillary imaging is extremely difficult and provides very little helpful information for assisting in treatment planning. Excellent. It really can provide a lot of information. This is a really unfortunate case in which there was only 1 really small lesion in the breast, and you can see all of the local regional spread. It is easy. The amount of radiation to the technician and the physician is extremely low, again because of the half-life of FDG being 110 minutes. We start the biopsy at 90 minutes post-injection, so that you're really out quite a bit of distance. Plus, because of the clearance in the kidneys, you actually have the woman void prior to starting the procedure. A lot of the excess FDG is gone, so it really provides a nice clear background. Which statement is false? There are no false positives with FDG and high-resolution PET imaging. All patients require high-resolution PET imaging. High-resolution PET imaging is not as sensitive as mammography. High-resolution PET is not as sensitive as MRI, or all of the above. And that also is very good. There's always false positives. There is no perfect imaging modality out there that I'm aware of. And the big false positive for high-resolution PET is fat necrosis. You will find a lot of FDG uptake in those macrophages, so that's a false positive. Do all patients require high-resolution PET imaging? No. I think in your fatty replaced breast, in a woman that's quite old, 85 years old, you're really talking about another 10, 15 years. You're really not talking about a 37-year-old where you're trying to get, another 50 years of life. So you have to use, you have to put everything into a clinical context on what you're trying to do for that particular patient. Are they equally sensitive? No. The average sensitivity for mammography overall is about 65% for index lesions, and high-resolution PET is somewhere between 93 as a low and 98% as a high for index cancers. So they are not equal in sensitivity. They are equal in sensitivity with breast MR. Both index and the satellite lesions were equal. Clinical case. 72-year-old woman with a bilobed lesion in the upper outer quadrant of the right breast. Let's look at that MLO view. Here's the MLO. We can see good pectoralis muscle. The ultrasound validated the mammographic findings, and these are the sizes provided by the mammogram. Conclusion was multifocal cancer. Question. The next step for this patient is schedule surgery for lumpectomy, schedule surgery for mastectomy, do additional diagnostic imaging. Well, I personally don't think it was that easy. She's on the older side. If she had had heart disease, I might just say, well, that's enough and we'll just take care of the lumpectomy. But you guys were right. It is do additional diagnostic imaging. And this is the high-resolution PET scan of that patient. And you can see no matter how hard you look in that mammogram, either prospectively or retrospectively, that additional lesion that was clearly identified on the high-resolution PET scan was not seen. This is a site in Turkey that this was their 5th patient that they did at that site using high-resolution PET. They were offering it across the board to all their patients as they were learning the technology, and found additional cancer. So for this woman, that lumpectomy would have had negative margins, but they would have left behind a cancer. And in a year or two, it would have been seen on a mammogram and diagnosed as a recurrent cancer when it was really there all along. And I think that is the most challenging thing about breast cancer, is that all of the lesions are different sizes. The index lesion and the satellite lesions can have different receptor expressions and different aggressiveness, and that sometimes they're really hidden and difficult to find, even with all of our imaging modalities out there. Last question. Are implant displacement views necessary for high-resolution PET imaging? Yes or no? A picture is worth 1,000 words. Here is the non-implant displacement view with our ability to see those 2 cancerous lesions, and one is clearly behind that implant, one is on the rim of the implant, so that it is very easy to see even recurrent cancer when you have a woman that's had a mastectomy, and in the United States we're doing a lot more nipple-sparing mastectomies. You then put an implant in and you're looking for recurrent cancer. You don't have to do the implant displacement views. You don't have to put a lot of pressure. You just have to use high-resolution PET, and if there's any recurrent cancer or residual cancer left behind, you will be able to see it. So thank you very much.